Another question. The reason I'm asking that is because there is a lot of opposition when it comes to the key population. Kwa sababu you might find people are trying to do a lot of programming, trying to influence the policy, but at the same time they don't want to be associated with the key population out of their reputation. Okay, are you getting that? I love you. Another thing, when you're talking about policy reforms, there are those policies that can be implemented that are going to actually favor the general population, especially the youths. Lakini kwetu the key population, we call them blanket policies. Considering as a young sex worker, a female sex worker, my job imekuwa criminalized. So when you talk about the assessing of the SRHR services, you're talking about maybe some of these social services that are being provided out there that other youths can be able to access. I cannot be able to access them because I am already criminalized. And they don't consider me as a young sex worker. Nikienda zile services, one thing napatananga nayo, wacha venye watu wanasema culture shock. Mimi shock ya kwanza ni, weni malaya, weni kahaba. Hapana hatukupati hizi services. Okay, and that's why you find a lot of young sex workers from the age of 15 to 24 years old wamejificha. And that's why I appreciate a lot of the sex workers-led organization. They are doing their best to go and get them so that at least they disseminate information on how they can be able and create a safe environment for them to be able to access these services. My other question, kindly, my other question to Mr. Israel about the online PrEP and PrEP delivery. Kwetu kama sex worker, it may not be applicable, it might be hard. Reason being, one, most of the people who are coming to deliver the PrEP and PrEP, ni riders, sindio? Anatumwa. Nimeorder from the app on my website, ametumwa nilete hiyo PrEP. Kitu ya kwanza, nafaa nipime, si ndio? Ndio niweze kujulikana if I'm HIV positive or not. Nikishatuma hizo results, one thing the AI ikisha detect yone kama ni positive ama negative, first thing anapigia ni rider ni mpatie kitu hii dawa fulani. This rider pengine kuna knowledge ati kama anapatiwa hii, anapatiwa PrEP na PrEP, mtu pengine ni positive ama si positive. Alafu hiyo ina create a lot of stigma na pain insecurity to us because you can even find that rider is somebody from my locality. The message that this person goes to dispense in the community, it can affect me. Socially, it's going to affect me. Another thing, kindly. Another thing, kindly, I'm talking on behalf of the key population. Tafadhali, wacha tu niulize. We are here to engage. As a matter of fact, you've given time to the panelists to talk. Let us ask this question. As a key population, by there, I feel left out in most of the forums. This is my time. Can you give me a chance, tafadhali? Alafu, when okay, this app, it's good by the way, lakini mbona nipe PrEP free, lakini the test kit and the condom I'm going to purchase. Kuongea ukweli, I'm a sex worker. Unaniletea PrEP, but at the same, I believe now there's an agreement with my dawa that it should be 50-50, okay? Lakini mimi kama sex worker niko street, pengine hata siweza kuaccess a health facility at the weekend, engage na app, nimeweza kuwatumia pengine niwapige order, mlete PrEP. Lakini nataka ninunue test kit, pesa nimetoka kazi na nunue test kit na kondo. Kuongea tu kweli. Hiyo ni ngumu sana. Alafu, the information that if I don't have a phone, I'm going to use somebody's phone to be able to access the app of the website, sindio? Na kama natumia kale ka simu ka kufinya, nitaomba simu, sindio? But some of the information will be retained in that account that I've used. It's not safe for me. Alafu, kindly as a recommendation, try and come up with a way that you can interact with it using a USSD code. For most of us as the sex workers wenye hatuna simu zenye zinaweza ingia online. Na hiyo swali ya who are the young people being addressed ya tafadhali ningetaka kujua.
Thank you so much. Sasa najua nilisema to engage, si ndio? Lakini pia time iko mbaya. Sawa. Time iko ati amna haraka. There is another session after. There's another session. So Elvis, I'm giving 1 second, and then we finish.
Hey. Okay, my name is called Davis Bulimo from a local village in Kakamega. You know, we've just been read so many bios, but we don't have time to ask questions. Hey. So I'm having a question here to my panelists. I'm starting with Isaac, Mr. Israel. I'm having just 2 questions, and they'll be very brief. Do you have the latest selling rates of test kits? And are you sure of the availability to the market? Because even these pharmaceuticals, they go with profit, okay? So that's the question I have. Then another thing is, you talked about stigma as a barrier. Can you compare, do you have some data to compare the stigma associated with self-kits and going to the VCT for the people that are testing fast? Then the question to Dr. Jonathan. You've talked more about care and treatment programs, but we have aspect of social determinants of health for these young people. Which programs does CDC have in terms of economic stability and education access? Because we might be having some LIPs that are doing good on care and treatment, but fail on other social determinants. Thank you very much.
Makofi. Trust me, ningetaka kuwapea nyinyi wote, but time is not on our side. Sawa. So allow me to allow the panelists to respond, and then nimesema mtawafuata. Sawa? Simko available. Mnaweza pale kwa beach mtabarizi. Sawa? I promise. Munihande. So Dr. Jonathan, and then Israel, and then Dr. Were will respond, and then we close. 1 minute each, quick. So we can start with Dr. Were.
Yeah, thanks. So I will. Thanks for the questions you raised. I will answer the questions around the online PrEP delivery, PrEP delivery model that you asked, and I think that's good user feedback. First, let me just acknowledge that around the model. One question you ask, why you need to purchase an HIV self-test kit while the PrEP and PrEP is offered for free. I think the reason why that is happening, so let's take it from 2 dimensions. Number one, visa services being provided in the private sector. So in terms of sustainability, we are looking at 2 potential models. One is a purely commercial model where everything is offered and you purchase it. Another one is public goods for in a private sector, which means the government could potentially, or other donors, could donate things like commodities. For that particular model, the PrEP and PrEP commodities were available in the government. So the government donated them for the study. HIV testing, we were using blood-based HIV self-test kits. They were not available in the public supply chain. And that is the reason why those client needs to purchase those ones for that particular pilot. The second question that you asked was issues around data privacy related to the smartphone. I may want to engage you more about that, because my understanding is that you are signing into your account, and that is where you are loading your pictures for the AI interpretation. So I would want to understand a little more about that. But also the other dynamic that you raise is about the issue about the potential for a USSD code. So I think go back to the presentation I made about differentiated service delivery models and think about it from that particular perspective. I think when we were creating this online model, the assumption is not that everybody will use that model. So there are people who will use that, there are people who will not. Part of the research I showed, although I went through it very fast, is, for example, PrEP delivery in private pharmacies, where somebody has to go physically. So I think from the differentiated delivery perspective, not everybody will suit that model. Probably that's a model for people who can afford, people who have a smartphone. It is not for everybody. And I just want to point out, we had an engagement meeting with the Key Populations Consortium. And I think some of these are the same things that came up, that really in terms of suitability of that model for key populations may not necessarily be ideal. But really thank you for the feedback. Then the last question was around the potential stigma emanating from the rider knowing your HIV status. While I can't totally rule out potential stigma because of that, but I would also just want to point out that issues about privacy, confidentiality are some of the issues that we have trained the riders. But that is not to say that there's a potential for unintentional disclosure of somebody's HIV status. And finally, some of these issues go back to my original hypothesis. Why we do implementation science research is to learn about interventions before we scale them up. And really some of this feedback is what is informing us on whether it is feasible to scale up some of these models. Thank you.
Thank you. Dr. Jonathan, 1 minute.
There are two questions. So thank you very much. I think very good questions and points, and I'm happy to engage further. One, Joanne, you asked about the definition in terms of the ages that we're looking at. So yes, we're looking at 15 to 24 years as, the young people. But, that's not like a hard number. If, for example, we have, a young mother, perhaps even less than 15, who presents and they need these services, then of course we would consider that as part of, the group that we, define as young people. Specifically further, you've mentioned about whether we are engaging young key populations. And indeed, part of our programming for key populations for the prevention program does specifically look at and address young key populations. And the way we work is, one, like I said earlier, through our large implementing partners, they actually do provide specific sub-grants to organizations and networks of key populations to engage in programming, to engage in demand creation for some of these services, and even service delivery. As you are aware, most of the services received for key populations are actually provided at drop-in centers. Those drop-in centers are actually supported by CDC, USAID, and other PEPFAR organizations that provide funding towards the healthcare workers you find there, the peer educators in those programs, as well as the training that they receive. So yes, we do directly get involved through our implementing partners and the sub-awards they provide to networks of key populations, including young key populations. And also now we are looking at what we are calling hidden key populations. These are populations that are engaging in perhaps either sex work or their key populations, but they do not necessarily identify as key populations or sex workers. So we are also engaging with those in ensuring we reach them. But for us to reach them, again, like I said, it's a conversation, because we need to know, for example, how do we reach these hidden key populations? Because there is a reason why they remain hidden. There is a reason perhaps why their risk perception is low. We would want to understand, we would want to hear more on how we can, even further, engage and reach them. The second question was by Davis, a very good question about social determinants of health and what you're doing about. And the reason I say it's a very good question is because indeed social determinants are key drivers of vulnerabilities to acquisition of HIV. And one of our flagship projects that I mentioned is actually the DREAMS program. And this specifically is in response to the data that we continue to see that one, HIV disproportionately affects young women, and it's because of vulnerabilities that are driven by the social inequalities. Specifically within the DREAMS program, there are aspects that provide them with education subsidies so that they remain in school, economic empowerment so that they're able to have knowledge about how they can empower themselves economically, including startup capital for them to start businesses. In addition, there's also the OVC program that targets children from in often vulnerable settings. Again, addressing some of the social determinants that make them vulnerable, and then of course vulnerable to acquisition of HIV. So yes, we do have specific programs. When you're out there, it might not come out as CDC, but those organizations that you work with, I can almost bet they're either
One
funded by
second.
CDC or our other sister organizations, that's USAID or DOD in the room. Thank you.
Thank you so much. Israel, you have 1 minute, please. 1 minute. For one question. We have another session coming in, that's why we need to exit.
Thank you. Allow me to answer all questions in one statement. I think I received majority of the questions about the selling rates. Actually, in Kenya, it's an open market. One pharmacy may be selling at a higher price compared to the other, but depending on the kit type, Ora Quick Retail is 500 to 600. Mylan, if you purchase it through Maidawa, at most you can get it at 250, but to the physical pharmacy, it will retail from 550 to 650. Availability to the market, HIV kits are available in the market. You can get it from the nearest physical pharmacy or order from Maidawa. Stigma associated with HIV kits. Actually, HIV kits were designed to offer privacy to these young people. So if we go to an extent of requesting for data for these young people, have lost that privacy the kit provides.
Thank you. Thank you, Israel. A round of applause for our panelists. I want to thank all of you, more than 100 people in the room with a lot of energy and questions. As has been said, the panelists are available throughout the conference. Please continue to engage with them. I want to wrap up the session by saying there are at least 5 or 6 key takeaways from this session. One, we have heard about the meaningful and ethical involvement of young people as a critical takeaway. Secondly, we have heard about engaging with and applying some of the private sector methodologies around market research, behavioral economics, human-centered design and segmentation into programming as a way of ensuring that we truly design for the user and with the user. And then we have heard about differentiated service delivery, and a key takeaway point from the young person is that we need to take services where the young people are. I want to take this opportunity to thank each and every one of you for having come for this session. Well done, and thank you, and see you around. Thank you.
So we can exit so that the people who are coming for the next session can come in. Yeah.
Oh, wow. Yay.